So yeah, today I'm presenting on my work developing recommended practices for the toxic drug and health alert system in BC, and this is work that I did with the BC Centre for Disease Control. And I'm also presenting a couple of my reflections on that, which is kind of tied into my culminating report where I chose to do a critical reflection. And I did this work on unceded Musqueam, Squamish, and Tsleil-Waututh territories and on unceded Lekwungen and Wasanich territories, which is where I am today. So as I said, my practicum placement was at the BC CDC in the Substance Use and Harm Reduction Department under the supervision of Dr. Alexis Crabtree. And there I was primarily doing policy and knowledge translation work in harm reduction. And this is all responding to the current public health emergency of toxic drug poisoning. So we have now entered the 7th year of the public health emergency of illegal drug overdoses. And since the emergency was declared in 2016, over 11,300 people in BC have died. And the unregulated and unpredictable volatile nature of the supply, which has been enabled by prohibition, is leading to these deaths. And social inequities like poverty and anti-Indigenous racism is creating further vulnerability and making the problem worse. So as an additional response, the BC CDC, in partnership with the Office of Virtual Health, have implemented a toxic drug and health alert system. And this is currently operating in all health authorities, wherein the health authorities are continuing to develop their own alerts, and then they're being put through the system and text to anyone who subscribes, as well as being posted on the Toward the Health website, or Toward the Heart website run by the BC CDC. And there's still work underway to revise and improve the system and to do a further evaluation. So my project was to develop resources to support regional health authorities and others interested in alerting in creating their alerts and making decision-making about those. And so I conducted a rapid evidence review at the same time as preliminary stakeholder consultations with different groups, including health authority, harm reduction coordinators, and peer networks. This culminated into a first draft of a recommended practices guide and guiding principles documents, which I will review in the next slides. Those went back out to stakeholders for further feedback, and then finished with good copies of those documents, which are currently under review with the BC CDC to be distributed to health authorities and published, as well as some recommendations for the BC CDC for future work. So the first product that I produced was a guiding principle guide, and this was really an acknowledgement, as others have noted, that public health involves more than just evidence. It also involves other forms of evidence like lived experience and principles, including principles like social justice and equity and inclusion of impacted communities. So I was trying to encompass all those parts of a public health response and a harm reduction response based on what I had learned from the literature and from consultations, and trying to emphasize the nuance and complexity that are in public health harm reduction interventions and in alerting. So the guiding principles developed were honoring that alerts are attending to the suffering and loss of human beings, to consider the complex tensions involved in drug alerts, and they provided examples to those, such as that this tends to be sometimes alarmist alerts work the best, and at the same time we want to be non-stigmatizing, and that this is a crisis that would necessitate a large number of alerts, but that can also lead to alert fatigue. So trying to emphasize the tensions that exist there. To ensure equity, to honor Indigenous self-determination, including in considering supporting First Nations to develop their own alert systems. To recognize the autonomy and knowledge of people who use drugs and involve them in all aspects of alerting. To recognize the crisis has structural determinants and where possible working to adjust those. To appreciate this as a novel intervention that will change over time, and to act with urgency. The second major document that I produced was a recommended practices guide, and this included recommended practices for developing a protocol for alerting, making decisions, how an alert should be designed, what content should be included, how the tone would be, how to distribute alerts beyond the text system, and concurrent responses, such as considering whether it would be possible to expand harm reduction hours and overdose prevention sites hours during times that an alert is being issued. So for example, for tone, the recommendations that I developed based on the evidence and consultations were to personalize the alert using language like you and we and relatable terms of reference like your body instead of the central nervous system, use non-stigmatizing language, and I provided guides there, to avoid an alarmist or sensationalist tone, and where possible to express safety, care, including cultural safety and trauma-informed care. As I said, I also wanted to have a critical reflection on this project that hopefully, in addition to learning and contributing practically to public health, I was also able to get a chance to learn and hopefully contribute in a critically reflective way. So one of my takeaways was really just public health, the value of integrating multiple forms of evidence, including elevating lived and living experience, local context, gray literature, and peer-reviewed research. And so establishing these recommendations was really an exercise in trying to embrace and involve all different forms of evidence into the guide. A second is the challenges and sometimes complexities in applied public health. And so doing harm reduction work was both enabled and constrained by working in a large institution. So for example, I had significant resources and expertise that I could draw from, including a panel of people with lived and living experience of criminalized substance use who I could bring my work to. And at the same time, I was also participating in an institution with power structures that have so often oppressed and marginalized people who use drugs. And so I was constantly needing to try to navigate how power structures I was embedded in were influencing my practice and where there are potential opportunities for challenging, working against, and changing that. And then a third related to that challenges is my appreciation to communities and the immense appreciation I have to the communities I was involved in working with and working for. And I think doing work in a crisis of what is essentially mass death is something that needs to be connected with feelings like rage and love and people and care. And so much of that I was drawing from with communities, including my dear friend Tara on the right. And so the support and advice that I got, I just really value and were a major part. And so with that, thank you to Dr. Alexis Crabtree and all the team at the BC CDC, Jeff Masuda, my friends Cedar, Tara, Colby, and then Brenda, Bruce, Bernie, and Daniel. Thank you.